today. This is the fifth meeting of the House Standing Committee on Health Services. We do have a robust agenda today. We are going to go ahead and ask any members if they have any introductions to make or any announcements. No? Okay. DJ, please take the roll.
Representative Bratcher. Yes. Representative Bray. Representative Burke.
Here.
Representative Callaway.
Present.
Representative Camuel.
Here.
Representative Dotson.
Present.
Representative Fleming. Representative Gordon.
Yes.
Representative Holloway.
Yes.
Representative Marzian. Representative Neighbors.
Here.
Representative Proctor. Representative Rayburn. Representative Raymer. Representative Riley. Here. Representative Sharp.
Present.
Representative Wilner.
Here.
Vice Chair Duvall.
Here.
Chair Mosier.
I'm here. Okay, we have a quorum established to do business, so we will go ahead and get started. We have two bills for consideration, and the rest will be for discussion only. I am going to come down to the table first to discuss House Bill 785, so if my guests can start making their way there, and we'll get started.
All right. If you'd like to introduce yourself for the record and have your guests introduce themselves.
Absolutely. Thank you, Mr. Chairman, and thank you to the committee members for allowing us to have a few minutes today to discuss House Bill 785. I am Representative Kim Mosier. I represent the 64th District.
Hi, I'm John Inman. I'm the Assistant General Counsel, Brightview Health. We're an outpatient substance use disorder provider in Kentucky.
Michelle Sanborn, President of the Children's Alliance.
Kelly McCormick, Chief Treatment Officer for Ramey ESTEP.
Very good. I think we have a sub.
We do have a committee substitute.
Okay. Do we have a motion on sub? We have a second? We have a second?
Thank you.
All right. All in favor say aye. Aye. All right. Any opposed? All right. Motion carries.
Okay.
Go ahead and proceed, please.
Well, thank you. And thank you for everyone's indulgence of our casual attire today. We're all in tennis shoes today as a Cancer Awareness Day. So if you see us in tennis shoes, that's what's going on. Today we're talking about House Bill 785 with a committee substitute. The committee substitute is a combination of the language from the original Bill 785, House Bill 785, and House Bill 787. This all deals with MCO audits, and 785 actually dealt with the MCO contractual compliance. I'm pleased to have some advocates with me here today who can really expound upon this and help us understand why this is necessary. This will help tighten up notification to providers about changes in contracts and denial of claims, and strengthens the ability to audit claims and a few other things. So I think I will hand it over to John. Do you want to go first and maybe explain what we were trying to accomplish with House Bill 785 and some of the problems that you've had?
Sure. I did not get the memo about the tennis shoes and the casual attire, so I wish I had. But again, I'm John Inman. I'm the Assistant General Counsel of Brightview Health. We have over 15 facilities in Kentucky, outpatient substance use disorder. Obviously, we contract with all the managed care organizations. But a portion of Representative Mosier's bill deals with the Mental Health and Addiction Parity Act. It is a federal act. Kentucky has a statute that I believe that you at least amended in the 2021 session, but it requires treatment limitations, among other things, to be the same between physical health and mental health. Also in the managed care rate setting regulations, managed care organizations are compelled to comply with that, and the rate setting is supposed to set equal payments between physical health and behavioral health and SUD. What we have seen is a disparity between those payments, oftentimes indexed to Medicare, the national Medicare rate, which is actually mentioned in the Department of Labor's self-compliance tool for health plans. It's oftentimes 50 to 60% of the Medicare rate, which is well below what we believe would be a commensurate service in physical health. So what we're doing is asking the department to actually put something in the contract. It is mentioned in a cursory manner between the state and the MCOs, but to actually put some guidelines and procedures in there to ensure that those parity requirements are actually monitored, that they're looking at sampling of providers and compared to a similar physical health field, and make sure that those payments, there's not such a huge disparity that we're seeing now. In addition to that, there are some contractual requirements that relate to amendments to contracts. It tightens up those. What we've seen is a lot of times the managed care organization will send it to either an outdated address, they'll send it to a facility address that is not a corporate headquarters, and a rate amendment, always reduction, will go into effect. The statute stands right now in the Department of Insurance statutes, that can be done multiple times per year. After 3 times, they have to send you a new contract, but they can do it 10, 12, 14 times a year, each time a rate reduction, which in perspective is the only industry that I know of in a contract that the buyer can perpetually amend the terms and tell the seller what they're going to pay them. So it is tightening up those to reduce that to at least a 10% rate reduction and only 1 time per contract term, because we've seen amendment after amendment come reduce our rates to again, even lower, 30-40% of the Medicare rate, as well as some other requirements in there about notice and delivery to ensure that the provider actually receives that amendment so that you can either object or accept those rates.
Okay, thank you. Michelle, would you like to explain your portion?
So our side of the bill has to do with audits and appeals. And it's really about setting some standards and some transparency around the audits and appeals process. And I had some nice notes typed out here to present to you, but I think the best way for you to understand why we need this and why we need this now is to share just 2 quick stories about why this is needed. In August of this year, many of our providers were receiving multiple requests for audits of their records. And one of our members reported 20 requests from the same MCO and or their third-party contractor within 3 days, with 663 records. Some of those records went back about 18 months. They've yet to hear back the result of that audit. Okay, we have another agency that just recently received a 376-page document in the mail for a recoupment. They were given about 10 working days to respond. They've responded trying to set up a meeting, can't set up a meeting with the MCO. $88,000 is being recouped from them as we speak. So they're not getting paid basically for the services they're doing today while they're appealing that recoupment. I don't know what their cash flow is like, but they're likely taking money from savings and losing interest, having to take a line of credit out. Many of our rural providers don't have $88,000 sitting around to make payroll this month for something that happened 2 or 3 years. Some of that recoupment was for that. So this bill would allow for the appeals process to be finalized before money is taken out of people's accounts, so they can officially win those appeals, right, before we take the money. So I'll let a provider here share some of their stories so you can get a better understanding of why this is needed and needed now.
Hello, everyone. So first I want to say we understand why audits are necessary, right? And we're not saying please don't ever do them, because we understand the process. We understand the necessary evil of that on our end. But what we are asking for is just this standard and some clarity in what's required of us. In 2024, our agency received what I would consider 24 significant audits, which is multiple charts for a period of 9 to 18 months that are all due within 8 days. One MCO sent us 2 significant audit requests within 4 days for 85 charts, and we had 8 days to turn those in. And then just a couple months later, that was followed up with a 145 chart request that was for a year that we had 8 days to respond to. It is being done well. There are a couple MCOs that we work with that do a great job. They may say, hey, I need 8 charts for this very specific service, and for 3 months, so that they can look at that. They come back to us with great feedback. They say, hey, here's some education, here's some information. Let's do better going forward. Hey, we got that, right? But that's not happening across the board. In these very large audits, we never heard any information back. We never got any feedback. If we do get feedback, it's something very arbitrary. It has nothing to do with the quality of the service or a question that the service was provided. It has to do with some very small detail somewhere that they weren't able to see, one, because they had 145 entire charts to look at, so they can't find all the information. So when those recruitments do happen, the money always ends up back in the MCO pocket within 30 days, when we have 60 days to appeal that by reg, and then that stays there until we can fix it several months later because of just the process we have to go through for the appeals and the complaint process. So we just are very supportive of this to help providers. It's very burdensome. I'm sure you all have heard about, providers talking about the Medicaid fee schedule, not paying for the cost of services. We don't have the funds to have one person, or 2 people is really what it would take to really put the effort into this. It's several people trying to come together and get these records together when most of the time we don't even know why they're requesting the records. There's no information with no feedback. So we appreciate your time.
Just a couple of comments to go along with what you have. And when the plans refer to an audit, it's really an abuse of the term audit. Audit is taking a valid sampling methodology of a portion of claims, receipts, reimbursements, whatever it is. And if you look at an actual audit of a company, or like a financial statement audit, it is a sampling of certain accounts to provide reasonable assurance that there's not a material misstatement. More often, what we go through as a provider is a full forensic review. And an audit is a collaborative process between the auditor and the auditee. This is not a collaborative process. What happens is there's unilateral communication. You're not provided any results or very summarial results of the audit, excuse me. And it's not a process where you're engaging with the auditor to try to understand their reasoning or why they're doing something. And what we've seen, especially from the audit or investigative units, that they can't really tell you why that they're taking it. Again, we agree with audits. We think that they're fine. There is also a prepayment review audit where the MCOs can stop all of your claims from being paid before they audit any of your claims. And that is terrible for cash flow for a small provider. Even in Brightview's case, again, we have 15 centers, but it's still a huge cash flow issue problem when you cut off all payments. It would be appropriate for a payment suspension if there's an allegation of fraud, waste, or abuse, but it's really a misuse of the term audit. Actually, in Medicare and Medicaid, their contractors, UPICs, ZPICs, MAC contractors, they actually have a Medicare and Medicaid program integrity manual that those contractors have to follow for each audit and for each circumstance. And a lot of times it has to be approved by the MAC or the Medicaid agency, and that's their own contractors. The plans are not held to those standards. They audit according to whatever they want. So there's no standard of review like there is for the Medicare and Medicaid program integrity manual, which really should be applicable in these cases as well to guide those audits for a standard.
Okay, thank you. So you see, we're just trying to apply some standards, some consistency in the audits. It does not change the fee schedule. It doesn't touch it. It extends notification, and it just creates some fairness in the audits and some expectations. And really, I think this strengthens the ability to partner with our MCOs in providing quality care, and that's really what we need to do. And so, our providers are out, in full force, doing what they can to provide care, and there are all these kind of distractions that we see really unnecessary. So, and on the transparency side of things, this requires an annual report of any Medicaid claims, any appeals, any grievances, so that we can see what kind of audits are being done, what kind of grievances are actually out there. The last thing I'll say before we take questions is in Section 8. This creates a new section of KRS Chapter 205 to require the Department of Medicaid Services and Medicaid Managed Care organizations to cover at least two, they're called E&M billable services. It's evaluation and management units per physician, per recipient, and per service for date of service. And so what that really means is, for example, if a patient goes to their pediatrician and the pediatrician is doing a well check, and in that well check they discover that the child has asthma or another chronic disease or some other issue that they need to deal with. As it stands now, the pediatrician can only bill for one well visit or one of those visits. What this would do is keep the patient from having to make another appointment to come back for that secondary service. Just allow them to get the service while they're in the office. It's a cost savings. It's more convenient for families, and I mean, it's common sense. So this is something that we've talked to the cabinet about. We just want to make sure that it happens. So that's why we added it here. And we're happy to take any questions.
All right, very good. We do have a question from Representative Wilner. Yes.
Thank you. Thank you for this bill. I appreciate the testimony so much. And when I hear from providers, especially mental health providers, which is a lot, these are the concerns, that these audits take place in a black box. You can't get a response. It's really terrible. And the issues around the mental health parity as well. Like, these are huge issues. I think so many of our mental health practices, they're tiny little practices. They're running on shoestring budgets. They are people who are interested in patient care. That's why they do the work they do. They don't have a lot of frills. And when they're doing the work and then money it's disastrous. We already have a shortage of mental health care providers in the state. And I'm just super grateful for this. I just want to comment as well, and I see Senator Meredith is here. We've had in interim health services committees, we've brought the MCOs in. We have bicamerally, in a bipartisan way, pointed out that all of these missions from the MCOs lack any attention to the providers. And without the providers, there is no health care. And so every opportunity we have to lift up these concerns and this really great legislation to address this is really going to improve health and outcomes in Kentucky, and I'm super grateful for this bill. So thank you.
Thank you.
Representative Fleming.
Thank you, Mr. Chairman. Thank you all very much, Representative Mosier, for bringing this to us for our attention. I want to ask some of your guests a question or two, if you don't mind. And that is, you've articulated, some challenges in terms of processing and audits and so forth. And I'm going to come, first I'm going to come from a business perspective. And when I have my employees, they're my first line of defense. And I support them to try to get them the best salary, try to get the tools to provide the service, and do what I can, and even the environment to do what I can. So I want to make sure that you all have the tools available to do the job. As Representative Wilmer mentioned, you're there to provide the service. but also each component, the provider, the MCO, and the DMS, each have a pros and cons with that. And you've articulated your relationships with the MCOs, and I can respect that. But I want to take a step back further. You and I have had some conversations, y'all, each one of y'all, and also in our budget review of the Health and Family Services. It seems to me that there is a serious concern on oversight and making sure that there is a cohesive, collaborative approach to providing service. And each component that I just mentioned has to play a part in that, and each has its faults in that. And I want to hear from you all in terms of an oversight perspective to give y'all the tools to do that, but also have some, fairness with the MCOs, but also make sure that DMS has the tools that they can apply whatever they need to apply in order to make service is delivered. So could y'all comment on the oversight and perspective of that? Because I know you deal with clawbacks, y'all deal with the rates, y'all deal with a lot of stuff. So I want to get y'all's perspective.
Sure, and thank you, Representative Fleming. I'll take that question. As far as we can tell, the Medicaid agency is fairly hands-off in any of these processes. Of course, there's a process to make a complaint on an MCO, but oftentimes they'll refer you back to the MCO if you have a complaint about an audit or reimbursement or a contractual issue. And a lot of it has to do with the MCO's adherence to the contract with the state, that the processes are skewed. So we as providers don't have a lot of control over that. I think that we are mentioned as in some portion of the provider agreement as third-party beneficiaries to that contract, but actually taking a live dispute to the department to arbitrate is virtually non-existent as far as what I can tell in my experience. And this is probably half of my job is dealing with the audits and the investigations and the negotiations for the plans.
I would agree with what he has said. We've talked about the oversight. There definitely needs to be. We see so many contract breaches of what is clearly in regulation to be able to work through these processes, and there's no repercussions on that. The repercussions come to the provider because money is sitting in the MCO pocket while this takes months to work through the appeal process, the complaint process through DMS, and as you guys have said, that as a small provider, we can't sustain that. So we don't have the manpower to continue to do this and continue providing the quality of services. Like I said, it's pulling from so many of our different positions when I could be focusing on quality care to the clients. And that's what we are here for. That's what we want to focus on. So if we could have a more collaborative process, that would be just ideal.
And I'd like to point out that in Section 7, we are authorizing the Commissioner of the Department of Insurance, to either suspend or revoke an MCO's certificate of authority for willful or frequent and repeated failure to comply with the mental health parity laws. So this does give some authority to the Cabinet or to the Department of Insurance to take action.
And we don't have in-house counsel, so we spend a lot of money contracting with our with a lawyer to help us look at this, because as I'm a clinician, I'm a therapist, right? So when these things are coming back, I don't know that what is coming to us is wrong, but when we send that to the lawyer, they're like, this is a total contract breach or against the regulations or something that can't be done. So if we weren't using that tool, we would just be losing money hand over fist because we don't know how to fight what's coming to us.
All right, very good. We do have a tight agenda, and we do have someone signed up to speak, so we'll try to keep our questions brief. Next is Representative Callaway.
Thank you, Chairman. I'll keep it brief. I'm looking at Section 3, and I'm curious as to how it's currently done. So we've got a narcotic treatment program shall be licensed by the Cabinet, and that's for to be eligible for reimbursement. So I'm curious about how that's done. And then Section 8, this providing coverage for evaluation and management services, for me, a layman, that seems wide open. Is that coding? Is there something, is that very specific to those practices? Like, I understand the need, and I applaud that, especially if there's an office fee that you got to pay every time you come back to be seen. So if you could just help me understand those two things, I'd appreciate it.
Thank you. Yeah, I'll take Section 8. John's going to take Section 3. But on the E&M code, it is limited to 2 per day per physician. So it is very limited. It's just saying, you know, if this child has more than one problem, that the physician can bill for treating both and not, you know, having to require the patient to come back for a second visit. Okay.
Yeah. On the narcotic treatment program section, so Brightview runs narcotic treatment programs. At the federal level, they're called opioid treatment programs. I think there is just a tad bit of cleanup language that probably needs to be done there. But opioid treatment programs or narcotic treatment programs in Kentucky law are certified by the Substance Abuse and Mental Health Services Administration under 42 CFR Part 8, as well as being required to have an accreditation and are certified by the DEA to dispense drugs for opioid use disorder, to dispense drugs. Some of the issues there that we've run into is the Kentucky regulations are much more restrictive on narcotic treatment programs than what the federal regulations are. So there may be a little bit of language to put in there, but it's overly regulated at the federal level, and then again, often conflicting regulated at the state level.
So we're just aligning.
Yeah. Try to align with the understand.
All right. Very good. Final question from Representative Marzion.
Thank you, Mr. Chair. Now, you said you had to sometimes give 145 charts when they're asked for an audit. Are there no requirements or regulations or anything that says they have 30 days before they can review them and give them back to you and there's nothing there that says that? So you have, okay. I don't know, maybe we can put that in the bill. Or it might be in there.
Yeah, in Section 6, it does extend the length of time to providers to 120 days to provide that information.
Thank you.
Yeah.
All right, very good. We do have someone signed up to speak, so we'll ask you folks to step away for just a moment, stay close in case there's a response needed, and we'll give him an opportunity to speak. Good afternoon. If you'd like to state your name for the record, and we're going to limit to about 3 minutes, or sooner or less if possible.
Less is more. Thank you, Chairman Duvall. My name is Tom Stevens. I represent the Kentucky Association of Health Plans, and we are opposed to House Bill 785. House Bill 785 comes at an extremely complex time for Medicaid, and we believe that this is actually a very complex bill to implement. Every day we're seeing stories about what the federal government may do and how that impacts Medicaid. And as Representative Fleming noted, we've seen testimony just in the last week, I think, to the effect of that a 1% change in the FMAP score for the state of Kentucky could have a $75 million swing. The Kentucky General Assembly is obviously paying close attention to this, as this body has demonstrated by passing House Bill 9, the MOAB. That passed 99-0 and is in the Senate now. The MOAB would create a bipartisan panel of stakeholders with a big mandate. It's effectively everything Medicaid in the state of Kentucky. The issue raised here are the exact types of issues that panel is made to deal with. And we would recommend that rather than take this issue on now with the complexities it creates with respect to contracting, potential abrasion, and a number of other things that I won't go into under the time, and we have not had the opportunity to review the committee sub, but we would recommend that is the most thoughtful, collaborative opportunity to address these concerns. And we do appreciate the opportunity. We have had an opportunity to speak with members of the Children's Alliance. We always appreciate the opportunity to meet with Chairwoman Mosier on her concerns, particularly in something as sensitive to the Commonwealth as this. Subject to your questions, Chairman Duvall, that's the extent of my comments.
Do we have any questions? All right, very good. Well, Representative Mosier, you'd like to come back to the table, and if you have a response to that, feel free to share.
Thank you, Mr. Chairman, and thank you, committee. I would agree that we are in a time of great uncertainty on a federal level as to what may happen with Medicaid, but that is outside of the purview of this bill. This really only deals with audits and the ability for providers to have time to respond, to make sense of what they're being asked for. And so I would submit that while this may not be complete, and there may be some things that we need to take up in Moab, and I am fully supportive of having Medicaid oversight and this advisory board. I think this is a good start. This is a good place to implement some changes that strengthen our providers' ability to provide care.
All right, very good. We do have a motion on the bill. You have a second? Okay, we have a second. All right, DJ, please call the roll.
Representative Bratcher. Yes. Representative Bray.
Explain my vote, please.
Yes.
I am going to vote yes. I do want to say this is a lot more complicated than I first realized it was. Ms. Bateman, this seems like the perfect thing for Moab to dive into once we get that stood up. Chairman Meredith, hopefully you all hear House Bill 9 very soon. It is probably the most important policy measure we'll take outside of House Bill 1 this session. With that, I am a yes. Thank you.
Representative Burke.
Yes.
Representative Callaway.
Aye.
Representative Camuel.
Yes.
Representative Dotson.
Yes.
Representative Duval.
Yes.
Representative Fleming. Representative Gordon.
Yes.
Representative Holloway.
Yes.
Representative Marzian. Representative Neighbors.
Yes.
Representative Proctor.
Yes.
Representative Rayburn. Representative Raymer. Representative Riley.
Yes.
Representative Sharp.
Aye.
Representative Wilner.
Yes.
Chair Mosier.
Yes.
All right, House Bill 785 as amended by House Committee Substitute 1 passes with favorable expression. Thank you.
Okay, thank you. Next, we will take up House Bill 61. Please introduce yourselves for the record, and we do have a committee sub.
Representative Steve Bratcher, 25th District.
Good morning. Emily Beauregard with Kentucky Voices for Health.
Lisa Biddle-Puffer, the Vice President of Quality and Regulatory Affairs for the Kentucky Association of Healthcare Facilities.
Afternoon, Chuck O'Neill, Director of Operations for the Kentucky Primary Care Association.
I do have a committee sub, if I could get a motion on the sub.
We have a motion and a second on the sub. All in favor of adopting the House committee substitute, please say aye. Aye. Any opposed? Okay. Please proceed.
Thank you, Madam Chair. This bill is a non-emergency medical transport. So right now, we pay through Medicaid almost $400 million a year through the state budget to provide transportation for those who can't provide transportation for themselves to and from a medical appointment. So it's non-emergency, it's non-ambulatory. So what happens is some of these areas are not getting the service that they need to get these routine appointments or routine procedures taken. So as a matter of fact, in 2022 and 2023, the numbers for the Department of Transportation showing that we had a 15% utilization rate, which means we're paying for services for 100%, and only 15% are getting this rate. So with this, I thought was alarming to me. But what happens is it even goes greater than that, because when a person doesn't get treatment or this non-emergency medical care treatment, their non-emergency treatment for an issue that's routine doesn't get taken care of, and it turns into either an emergency or a perceived emergency. So now they call an ambulance under Medicaid. They're transported to the emergency room under Medicaid. They go into the hospital under Medicaid. Medicaid's paying all this bill, which is 10 times more than what a non-emergency medical transport would be charged. Then they stay in the hospital 2 to 3 days longer than they should because they don't have transportation out of the hospital. So as I dug into this, I started realizing I met with Transportation Cabinet and met with others, and this is just a bigger issue that we can resolve in this session. And so what the committee sub does is I pulled it back, and it just asks for a study to be accomplished, and it allows some of the organizations that are being affected the most, like the nursing homes and hospitals, allows them to provide non-emergency medical transport to and from their appointments if the broker or the provider can't provide it. So and then it also, when the contracts come up with the state, there's 15 different regions. There's 8 different brokers. The brokers they'll submit an RFP and bid on it. So half of them come up in 2025, and the other half come up in 2026. What this bill also does is expands the contracts for 1 year, and then that gives us time to do the study to evaluate the entire process and understand what is going on with the $400 million that we're providing with 15% utilization rate. So that's what the committee sub does, and that's pretty much the entirety of the bill.
Okay. We have a motion. Do we have a second? Okay, thank you. Do we have any questions? Representative Fleming.
Thank you, Chairwoman. I just want to compliment Representative Bratcher for taking this. I think this will lead right into Moab. And given that you put an extension for 1 more year, it gives us time to go through and digest everything. So this board will be able to basically peel this back because it is very complex and involves a significant amount of money. You said $400 million, and I know there's several tiers in terms of pricing and compensation. So that has to be flushed out and so forth. So I do appreciate this to be very, very timely, and I appreciate your initiative of doing this.
Thank you, Representative Fleming.
Okay. Thank you. Okay, seeing no further questions, DJ, please take the roll.
Representative Bratcher.
Yes.
Representative Bray. Representative Burke.
Yes.
Representative Callaway.
Aye.
Representative Camuel.
Yes.
Representative Dotson.
Yes.
Representative Duval.
Yes.
Representative Fleming. Representative Gordon.
Yes.
Representative Holloway.
Yes.
Representative Marzian. Representative Neighbors.
Pass.
Representative Proctor.
Yes.
Representative Rayburn. Representative Raymer. Representative Riley. Representative Sharp.
Aye.
Representative Wilner.
Yes.
Chair Mosier.
Yes. House Bill 61, as amended by the committee sub, passes with favorable expression. The same should pass on the House. Thank you very much for this good legislation.
Thank you, committee, and thank you, Chairwoman Mosier.
Thank you. Okay. All right. Next on the agenda, we have House Bill 788. And what I would like to do is, this generated a lot of questions, a lot of conversation. And so what we're going to do is invite Dr. Pat Murphy to the table to discuss this today. And we will not take it up as an item for passage, but we will spend a few minutes answering some questions. So thank you for being with us. Please introduce yourself for the record and proceed. Will you turn your microphone on, please? Green light. And then just pull it close.
Thank you.
Thank you.
Representative Moser. It is an honor to be here. I appreciate being here. I was back here in October, if you recall, and we talked about this issue. And I'm back here again because there's a bill now, House Bill 788. And Representative Moser asked me if they could help elaborate on this and give some context to it. So I'm going to respect your time. I'll be brief here, but I want to talk about a little bit about what this deals with, which is the medication buprenorphine, what it is, a little history behind it, and how effective it is, and why this bill is important. The medication we're talking about here is buprenorphine. What it is a lot of times you heard about the trade name Suboxone. It comes in other forms as well, though. There's an injectable form of it. This medication was actually came about in 1985, and it's been used to treat opioid use disorder in doctors' offices since the year 2000. That's 25 years ago. A lot has changed in 25 years. A lot of science has happened. We've learned a lot more about how this medication works. What buprenorphine is, it's an opioid, but it's a partial opioid. It is not an opioid like morphine or methadone or heroin or anything of that nature. It has a ceiling effect. And that's important for safety perspective because this medication, once it gets in your body and once it attaches to the receptors and works like a medicine does, when it hits that ceiling, the effects don't get greater. And that's important because the number one reason people die from opioid overdose is they quit breathing. Now, I'm not here to say to anybody watching or listening to this that this medication cannot be abused or that it is entirely safe. But when we compare it to our other option, methadone, it's so much more safe than methadone. So safe, in fact, that our government, our federal government, allowed all of the physicians to prescribe it out of their office in the year 2000. Let's move forward a little bit. At first, I could do 30 patients total. About a year later, they said we could do 100, then 275. They did away with some of the required training for it because it's so easy to prescribe. They said you no longer have to do counseling along with it. We recommend it, but that's not going to be a requirement. In other words, over the years, the past 25 years, we've learned so much about the effectiveness of this medication that in 2022, all of the federal regulations were done away with. There are no longer any specific federal regulations regarding buprenorphine to treat opioid use disorder. So you can treat it. Any doctor, nurse practitioner, anybody with a DEA license can treat opioid use disorder from their office to as many patients as they want at whatever dose they feel is necessary. In other words, they can individualize the care to the patient they have in front of them because everyone's journey in addiction is different, and we have to have individualized care. So how effective is this medication, though? Well, let me tell you a little story myself. We've read about this. It's very effective. We have studies done and research in Kentucky that show its effectiveness in decreasing crime, decreasing diversion, and saving lives as well. Nora Valkow, who has been here before testifying in years past, she is the director of the National Institute of Drug Abuse, NIDA. She's been to Kentucky. She came here in October of last year. I sat on the front row right next to our president from the University of Louisville. I'm a professor there. Dr. Valkow has told us that if everyone who needs this medication, buprenorphine, could have access to it, we could drop our overdose death rate by 50%. And she said that's a conservative estimate. Now, last year, we had about an 8 or 9% drop in overdoses in this state. And that's great. And we want to tout and celebrate every drop in overdoses that we have. But we have more Narcan out there. There's probably a little less fentanyl in the supply now. And I think we are doing a lot of things to treat this condition. In other words, we've heard about these groups that have come up here and they're doing things like, we have a lot of beds in Kentucky. We have a lot of access. People are working to get treatment to people. But what we're not doing is treating the actual disease of addiction that's causing the overdoses. And buprenorphine works in that part of the brain. It's like putting water on a fire. It works in that part of the brain to stabilize the part of the brain that causes the behavior. Right now, we have barriers to access to this care, unfortunately. A lot of it is stigma. People don't understand it. Part of the reason I'm here is just to educate you on this, because it starts with learning what this is. Because once we understand what it is, it's not trading one dependency for another. It's actually treating the disease of addiction. And the problem is that we don't have enough people that can prescribe it now. I mean, as I said, the federal regulations are gone, and most states don't have buprenorphine specific regulations. Only 19 states do. Kentucky's one of those states. And these regulations can't keep up with the science, no matter how hard you try, no matter how much you put effort into it. By the time a regulation passes, it's probably obsolete. The science is moving so fast, and the SAMHSA, you've heard about SAMHSA, the Substance Abuse and Healthcare Services Administration, the Federation of State Medical Boards, the DEA, HHS, I could go down the line. They all support low barrier access to this. And there's one group that I want to end on to let you know who supports this. And this may shock you. Because of those of you who are worried about diversion of this medication or what's going to happen with this, think about this. In January of this year, the HHS and the DEA published in the Federal Register that they want to allow buprenorphine to be prescribed by telephone without ever having to see a patient face to face. I'm not recommending that happen to everybody, but there's going to be certain cases where you might want to do that. The DEA, not known for being a group that will go easy on drug diversion. We look to them to do that. But the DEA, look it up. Look it up. In January in the Federal Register, Google it. This year, the DEA has said that you can do this. This is such an effective medication. We want our providers to be able to prescribe it however necessary, as long as they feel it's proper, as long as they're practicing medicine, and as long as they do, in this case, a CASPER report, for example, in Kentucky. So it's not the wild, wild west if we allow this to happen. Buprenorphine is still going to be a Schedule III drug. There's still a regulation in Kentucky that will govern all scheduled drugs. It's called 201 KAR 9260. There's a section in there where buprenorphine fits right in. But we have to enable and empower our prescribers. We have potentially 26,000 or so prescribers in this state that can prescribe this medication. About 2,000 or 3,000 prescribe it right now. Only about 20% of people who need this medication get this. Our overdose rate is at record levels still. We had about 245 or 6 overdoses in 2000. In the year 2000, we had almost 2,000 overdoses last year. We have a medication that can drop this overdose death rate, science says this, by perhaps 50% or more. We just need to empower our prescribers to do it. And House Bill 788, what it does is helps remove one of those barriers, and that is that the fear that prescribers have that they might lose their license or get penalized by inadvertently or just not following one of the regulations, exactly. And that does happen. A lot of prescribers that I talk to, that I know, they say, well, the best way I can avoid getting in trouble with the medical board or losing my license is just to not treat it. And that's really, really sad. Kentucky deserves care. We are doing so much in this state to fight this problem. There's one missing piece. There's a missing piece that we have, and that's to get our primary care physicians comfortable prescribing this medication that we know by science is effective. And I say this not just as a prescriber in Kentucky. I say this as a parent, as somebody who lives here. I'm a professor at the University of Louisville. I am the regional director of the American Society of Addiction Medicine. We are behind this, and I appreciate this House Bill 788. We've looked at this, and we agree with this. We feel it is a good bill, and we hope that you will consider that carefully. And I thank you for your time. If you have any questions, I'll be happy to answer them.
Thank you so much, Dr. Murphy. I really appreciate your time and your expertise. And I also want to thank the Kentucky Board of Medical Licensure for considering some of the flexibilities that we're suggesting. I know that they are working currently on reworking these regs, but it's still, to me, it seems overly prescriptive in dictating exactly how many patient visits need to happen, exactly how many urine drug screens, exactly what the dosage should be. I think that we want to trust our doctors. You all are trained to provide the care, and we don't ask other specialties to do this. If they prescribe medication, if a cardiologist prescribes Lipitor, we don't say you have to have your patient come back every 2 weeks and you have to do labs, and we just don't do that. We trust our providers to provide that individualized care, and so that's all we're asking. Physicians and providers would have to follow medical best practice standards, and those are all dictated in all of the subspecialty groups, as you mentioned. And the last thing I'll say is I think that this should be treated as any other Schedule III drug. We already have protections in place, and we have the Kentucky Board of Medical Licensure has the ability to audit those prescriptions through CASPR and the other things that we do around scheduled drugs. So are there any questions from our members? Yes, Representative Duvall.
I just want to say that I believe that guardrails are helpful, but micromanaging is detrimental.
Okay. I guess we don't have any other questions. Thank you so much for your time, and I think this is a great conversation, and that's what I wanted to happen. So thanks for being here.
Thank you very much.
Thank you. Okay. All right. Next, I would like to invite Senator Meredith and your guests to make your way to the table for a discussion around Senate Bill 14.
Thank you, Madam Chair. I'm Steve Meredith, State Senator from the 5th District, and I've asked my guests to allow me to present this first, talk in great detail about this bill. It's mentioned as 340B legislation, but I assure you it is not. It has nothing to do with the 340B program, because that's a federal program. There's nothing we're going to do in either of our chambers that are going to change 340B and how it's administered. My bill simply says, and if you have it in front of you, 3 sentences on 16, 17, 18, a manufacturer shall not discriminate or cause others to discriminate against a 340B entity by refusing or withholding 340B pricing for a covered drug if the manufacturer offers the same drug at a 340B price in any of the states. So in essence, it says Kentucky should not be discriminated against. And Kentucky is not the only state that's had to deal with this. There's numerous other states, as a matter of fact, 30 have taken actions to keep the pharmaceutical companies from withholding these discounts. But if you want to talk about 340B, it started in 1992. And I'm going to read you the direct quote from their website. Is in the intent of the program is to allow covered entities, and a covered entity is one that sells a disproportionate share of Medicaid patients, covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services to serve the nation's most vulnerable patient population. And that's exactly what we do. What's happening right now is the manufacturers, pharmaceutical manufacturers, are arbitrarily and capriciously deciding they're going to withhold these discounts, withhold these drugs, because they don't want to incur that expense anymore. They agreed to this in 1992 because they were afraid of price controls. And President Bush said, in exchange for that, we want you to give these discounts to qualified entities so they can sell these drugs at the retail price and use the profits to fund these vital services. And they are vital. I hope you're aware, and I know I've preached about this a lot, but rural health care is on its knees financially right now. A recent article is recent as last summer that 13 of our 71 rural hospitals are at risk for closing. In 340B funds, it's not additional funding, it's a financial lifeline for our communities. And let me share with you some of the communities that are going to be at risk, because it's just not healthcare we're talking about, it's the economic foundation for many of these communities. Some of you may know these cities. 15 listed with negative total margins are Fulton, Pineville, Irvine, Carlisle, Madisonville, Shelbyville, Albany, Manchester, Owington, Mount Sterling, Marion, Burkesville, South Williamson, Campbellsville, and Russellville. 10 are cited that they lost money on patient services, and overall, Pineville, Irvine, South Williamson, Marion, Mount Sterling, Shelbyville, Albany, Owington, Manchester, and Fulton. 19 lost money on patient services, but not overall because they had some other resources such as local taxation to take care of them. Martin, Columbia, Prestonsburg, Benton, Hazard, Paintsville, Danville, Greenville, McDowell, Harlan, Salem, Middlesboro, West Liberty, Carlton, Russell Springs, Monticello, Tompkinsville, Harrisburg, and Whitesburg. Yeah, this is not just additional monies for these facilities. This is their lifeline, and it's just not for rural hospitals. You have a clinic, Representative Gordon, in your district, FQHC, that uses their 340B funding to provide transportation to patients to the Marquis Cancer Center. The new hospital in the west end of Louisville, will tell you, is supported in large measure by 340B funding. Arkansas sued the pharmaceutical manufacturers for withholding these discounts. Went to court. They won. It was appealed. Federal court. They won. They asked the pharmaceutical companies asked the U.S. Supreme Court to hear the case. It said, no, you have to follow the law. That's all we're asking here. Again, we're not going to change the 340B program. And I'm the first to admit there's problems with it. It needs to be looked at. But you should also ask yourself this question, if it's so problematic, why hasn't Congress dealt with this? Why? Because they know it's vital to rural America and vital to rural Kentucky. If we do not protect these funds, I guarantee you we will create not just a healthcare catastrophe in Kentucky, but an economic tsunami that we've never seen before. For many of these communities that I mentioned to you, their hospital is their Toyota, their Amazon, their Nucor. It's a primary employer in many of these communities, and they cannot survive without this funding. We've mentioned repeatedly about the potential loss of Medicaid funding, which we know is going to happen. If that trickles down to our rural communities and rural healthcare providers, it's just going to push them further over the edge. So this is not legislation I just ask you to consider. I'm begging you. I wouldn't care if I carried another bill in the rest of my career in this legislature, but we have to have that. It's that vital for the survival of rural Kentucky. And people don't understand that if rural Kentucky fails, this state fails. It's nice to think that if you live in an urban area that you can stand alone. You can't, because you rely on us for your retail dollar, your medical dollars, for your recreation dollars, and a good source of our labor supplies. We just want access to care like everybody else, and this is going to take it away from it. There's a lot of damning statistics I could give you about rural health care, but the one I think is the worst, that 40% of our population lives in rural Kentucky. Only 17% of our primary care physicians are there. Why? Because of lack of funding, too much Medicaid. So again, I'm telling you, this is a lifeline. It's not a luxury. We can't live without these dollars. And if it goes away, if we give pharmaceutical companies latitude, it's going to crush us. But I think it's interesting that they've spent so much money advertising against this. Matter of fact, I have a sister who lives in Tennessee, and she told me last night, I saw a commercial about you, that you're a bad guy, that because you support this particular program. I go, really? We're talking about a potential impact of $250 million in Kentucky if we lose this funding. The average compensation package for the top 10 CEOs of pharmaceutical manufacturers is $25 million each. Do the math. 10 guys, $250 million. What's it mean to Kentucky? $250 million. Now, they're saying that if we continue with this, the drug prices are going to increase. It will not. There's nothing in this bill that increases 340B utilization. Nothing. But they'll give you that line, and they shouldn't. But I guarantee you, if these fundings go away, it will not reduce the cost of prescription medications in Kentucky or America. All it's going to do is increase the bottom line of pharmaceutical manufacturers. So again, this isn't just a request. I'm begging you, for the sake of rural Kentucky and the sake of Kentucky overall, we have to pass this legislation. If not, I shudder to think what the future is going to be for us. Our Medicaid program has exploded. We're going to have to reel it in. But the biggest cause of the expense that we see in the Medicaid program is the health of our Commonwealth. Closing rural hospitals, is that going to improve the health of our population? No, not at all. Is it going to help recruit doctors to rural Kentucky? No, it's not at all. And this isn't about providing, money to hospital. It's vital services. The use for oncology programs. I got one hospital in my district that uses it to supplement nurses' salaries. They have to, because they're between Owensboro and Elizabethtown and Louisville. They can't compete with the salaries. So they have to use this to supplement their salaries to provide basic care for their community. Got one hospital uses it for a food bank that they do within their hospital. And the list goes on and on and on. Vital services that maybe people take for granted in the urban areas, but not rural Kentucky. We're drowning out there. And while we're seeing the unparalleled economic expansion in Kentucky over the last 4 or 5 years, it certainly hadn't trickled down to rural Kentucky yet. I hope and pray that it does, but this is our last line of defense. We rely on our school systems and our hospitals to be the major employers for our communities. And if we let this money slip away, we can't survive. Madam Chair, I know that there's several people here that are impacted this as well, and don't know what your schedule is for allowing them to testify, but I certainly appreciate the opportunity to speak to you this afternoon. And so,
thank you. I really appreciate your time and your testimony, and we certainly want to protect our safety nets and our hospitals' ability to provide the care. I just think that there are a lot of questions out there about exactly how much money is involved and what it's funding, and so I think that there's a need for a little bit of transparency around this.
I appreciate that, but bear in mind that this is not funded through our Commonwealth. It's not funded through the federal government. This is funded through pharmaceutical companies providing these discounts to us.
So I have a question.
Yes.
So how are the rates set currently for the drug pricing?
Well, it varies, but again, it doesn't really matter what the price is because it's going to be monitored and controlled by the insurance companies in the Medicaid, Medicare program.
Well, but the low negotiated rates that I'm talking about are set on a federal level through
They
this
are.
340B program.
The intent is to give a 25 to 50%
And so the
discount.
manufacturers are obligated to comply with the terms of that federal program. Congress has 2 pieces of legislation right now. They're looking at program integrity and whether or not this original legislation was constructed in a way that provides some guardrails around an explosion of or abuse of the program. And I'm not saying that anyone is abusing the program. I want to
Not in
support our
Kentucky.
hospitals.
If you do, again, this is not going to cost us anything.
Yeah, that is all we need to find out. So are the rules for the manufacturers are also set in this federal program, correct?
They are, but I mentioned again, there's nothing we're going to do to change the 340B program. That's federal. All I'm asking is don't let Kentucky be discriminated against. And that's what's happening right now. If you got 30 states that have taken legislation or court action to protect their funding, is Kentucky going to be the last man standing? Are we going to be the poster child for 340B reform? I don't think we should be. We can't be. Again, all I'm asking is treat us fairly. Let us have these dollars that Congress intended us to have to serve our most vulnerable communities. Why would we deny that? Transparency? I'm all for that. But you collect all this information and 340B entities, and these folks back here can tell you, there's a wealth of safeguards in there already. And the amount of data they have to provide to the federal government is overwhelming. But we collect all this data. What are we going to do with it? We're going to deny payments to them? Well, we can't because it's not our money. Are we going to recoup payments to providers who maybe haven't used the funds appropriately? We can't do that because it's not our money. But I guarantee you, I've asked, show me one facility in Kentucky that has abused this program. Just one. You're not going to find it. But what you're going to find is people who are providing basic services to people that otherwise we wouldn't have, we couldn't have. So again, I hope the federal government takes control of this. I hope they will fix the problems. But in the meantime, we have to protect Kentucky, particularly a lot of these Medicaid cuts that we're going to see coming down the pike, plus what other cuts we may have coming down the pike. You have to protect this. I'm begging you.
I have a quick question. Did you see a reduction in the savings from this program last year when we didn't pass Senate Bill 14 or whatever the number was?
We have. It's happening every day, and it's hard to keep track of because the pharmaceutical companies are, again, arbitrary and capriciously saying, we're not going to give you this drug, or we're not going to give you this discount. So it's hard for us to know this, but we know what the impact is if we don't do this. It's a loss of $250 million.
So the manufacturers are not complying
No,
with
they're not.
the federal rules.
They are
Well,
not.
there are, there are stiff penalties and they would lose contracts. So I think that, I agree with you. They should be adhering to and complying with the program.
Well, 30
Is it the
states wouldn't
federal
take action to
government who
control
is
that
not-
if they weren't doing that. They're already saying 30 states have had to take action to protect their 340B pricing in the distribution of drugs. I'm just saying Kentucky's got to do the same thing.
Mhm.
We're going to lose it.
Okay. The reason that it's come to everyone's attention is because it has expanded 4,000% in recent years. It's the contract pharmacies are growing. The program is growing, and I just
Excuse
think
me, how
that-
much has it cost Kentucky? And we're not
well,
just,
that's why we need some reporting. So yes, you're right. We need to understand that better.
But in the meantime, we
have a
lose
couple of
potentially $250 million.
Representative Bratcher, do you have a question?
Yes, Senator. Thanks for your testimony today. Just a brief question or two. Was this designed for a profit? Does this go for profit hospitals or
No.
nonprofit? So it's just nonprofit hospitals?
Not-for-profit governmental entities that serve a disproportionate share of Medicaid patients, the poorest of the poor.
And how do we know that the money that's supposed to be going to vital, quote, vital programs is actually going to vital programs?
They are subject to audits, and you have to be recertified for the program annually. The government requires paperwork on this that you would not believe. And again, my colleagues here can tell you that it's overwhelming at times, the amount of information they have to provide, but it is verified by the Health Resources and Service Administration, which is a branch of CMS.
Thank you, Chair. Thank you, Senator.
Thank you. Representative Bray.
Thank you, Madam Chairwoman. First, let me say thank you for the bill. Very supportive of the bill. It's get really ticked off when it seems like the little guy's getting picked on. And so my part of the state I come from, I've got a heck of a hospital. They don't ever ask me for anything. They don't want anything. They just want to be left alone. They want to get what's coming to them, and they want to provide care to patients. So over the summer, they brought me in and said, hey, we've got a real problem with what's going on with 340B. It's the first time I'd ever heard of it. No clue. So they walked me through the numbers. And I asked them, I said, how do you all use 340B in Rockcastle County? And what they said, oncology. We provide cancer care to patients here so they don't have to drive to Lexington in order to receive cancer care. Mental health services. They provide counseling through the school system for troubled kids because that's the quickest way that we can get access to care to the patients that need it the most. They provide telehealth with the pediatric department. Anytime a kid's sick, they've got the ability at school to telehealth with the doctor in order to get whatever medicine they have in order to get care. I don't really care what's going on outside in corporate world or with big pharma or anything, but I do have a real problem when it seems like the little guy's getting picked on, and when we've got these small hospitals who get by on the tiniest of margins anyway, and it seems like they're being discriminated against because they can't fight back. And it seems like your bill's a pretty simple solution that just says you can't discriminate against Kentucky, hold your end of the bargain, whatever you bargained for from the beginning, and honor your deal. Thank you, Madam Chairwoman.
Thank you.
Thank you. Representative Dotson.
Thank you, Madam Chair, and I appreciate the passion from Senator Meredith right here. You said there were 30 states that had already taken this up for protections in their state. 8 have already passed it, if I'm correct.
Yes.
And Arkansas adjudicated it, went all the way to Supreme Court, and it held up in Supreme Court. Could you give us a little backdrop on that?
Exactly the same situation as Kentucky. Arkansas is being denied access to 340B drugs into the pricing, so they sued to make them honor it. They won at the local level. They won in the Court of Appeals. The pharmaceutical manufacturers asked it to be appealed to the U.S. Supreme Court. The Supreme Court said, no, we're not going to hear this case. You have to abide by the law.
Thank you.
Okay, thank you. All right, seeing no further questions, I really just want to thank you for your passion and, sorry, Representative Proctor, I'm sorry, I didn't mean to skip over you.
Thank you, Madam Chair. Thank you, Senator Meredith, for your testimony. As I'm learning more about this 340B, my question is this only really for rural, or are there wealthier urban hospitals that may be not-for-profit and say they're safety net but have a pretty significant operating budget and yet very little goes to charity care? Are these hospitals eligible for this program, and are they benefiting, or is it truly just for rural?
No, it's for urban areas as well. As I alluded or mentioned earlier, that the new hospital in the west end of Louisville, owned by Norton Healthcare, they are recipients of 340B, and one of the primary reasons they're able to operate that facility in the west end of Louisville because of 340B. So it's not just rural areas; it's any facility, any entity that serves a disproportionate number of Medicaid patients, and that's got to be tested every year by the federal government as well.
Okay. All right, thank you. Again, I really appreciate your information, your passion about this. We want to protect our hospitals. We want to make sure that these programs are indeed reaching our more indigent folks, some of the poor areas of our states, to really bolster the health care that we can provide. All we're trying to do is help the federal government inform policy decisions if there are any to be had, and I think it would give everyone comfort in knowing where these programs are and exactly what the services are that are being provided. So thank you for being here today. We're going to hear from some other folks
Thank you.
On this issue. And this is in regards to House Bill 685, which is for discussion only today. And this is a requirement for reporting, and here to talk about some of that is Dr. Bill Smith, who is a senior fellow and director of the Life Sciences Initiative at the Pioneer Institute. He flew in from Boston to talk to us today, and then Frank Gemley is here with the Association of Manufacturers, and I see that Dr. Kyle Keeney is also here, Life Sciences Executive. And then I believe, do we have Jenny Goins, who's the Chief of Staff?
Yes,
of the
ma'am, I'm
National
here.
Alliance on Healthcare Purchaser Coalitions. She's on Zoom. So we're working to get you up. There you are. Okay, thank you everyone for being here with us today. And so we're just going to talk a little bit about what our ideas are about reporting. I think Dr. Smith, you're going to talk maybe about the program. So if you all can just introduce yourselves for the record and proceed with your testimony, welcome.
Bill Smith, I'm a senior fellow at the Pioneer Institute in Boston.
Dr. Kyle Keeney, founder, CEO of Kentucky Life Sciences Council.
Frank Gemley, Kentucky Association of Manufacturers.
Jenny Goins, National Alliance of Healthcare Purchaser Coalitions.
Madam Chair, thank you for the invitation to your beautiful state. I don't come here representing any specific interest. Why am I studying the 340B program? Well, the reason is that our think tank is located in the greater Boston area, which has the most important concentration of biotechnology, academic, and pharmaceutical research in the world. And so our think tank studies policies that might impact that adversely or benefit it. So I've been studying 340B for about 3 years. I have a few slides, but feel free to rush me. I know you have a packed schedule today.
Okay, your slides are up.
Okay, thank you. So as I said, I represent the Pioneer Institute in Boston. Let me give you a little history on this program. So in the 70s and 80s, Medicaid was a very small program compared to what it is today. There were a lot of uninsured folks out there, and there were safety net hospitals, maybe 300 or so, that were treating large numbers of uninsured, and they were having to eat the costs of treating them. They weren't getting reimbursed. And so pharmaceutical companies in that time, in the 70s and 80s, stepped in and they gave these hospitals voluntary discounts that were very generous, deep discounts. And under the heading of no good deed goes unpunished, in 1990, Congress came in and passed the Medicaid best price law, which says that drug companies have to give the best, lowest prices that they give to any customer in the United States to all 50 state Medicaid programs. Well, this threatened the voluntary discounts that they were giving to the safety net hospitals, because the hospitals were fearful the discounts were going to be withdrawn because they were going to have to be passed on to all 50 states. So the hospitals went to the Congress, and in 1992, they passed the 340B statute, which exempted these drugs from the best price law, and it started the program off. And just so you know, there are many ways to become eligible for 340B discounts, but the primary way for hospitals was if they had 11.75% of their patients as Medicaid patients, they could be eligible for the discounts. So that's what 340B is. Here's what 340B is not. It's not a drug discount program for patients. So there's no statutory requirement that the drug discounts that hospitals get passed on to patients. And government watchdogs have studied this issue, and the best study I've seen came out in 2022, and it estimated that only 1.4% of patients from 340B hospitals accessed the discounts at the pharmacy counter, and 7% of patients pay cash because they're either underinsured or uninsured. So the discounts aren't being shared with patients. The most important thing to understand about the 340B program and what drives its revenue is arbitrage. And what is arbitrage? Arbitrage is just a Wall Street term. It means if you want to make a profit, you buy low and you sell high. And so what does that mean in this context? What that means is that, for example, the average oncology drug now has a list price, new oncology drug has a list price of $200,000. We're talking about very sophisticated oncology, CAR T therapies and others. $200,000 is the average. Now, if a 340B hospital can purchase that drug for a 50% discount, which is not atypical in the 340B program, if they can buy it at a 50% discount for $100,000, they can bill Medicare or they can bill an employer's health plan for $200,000, and they can pocket $100,000 profit on one prescription. So Medicare, it is not the case that the American taxpayers are not funding this program. They are, through Medicare, overpaying for drugs. And why is this a policy problem? Well, as I said, there's an incentive in this program to bring in insured patients, not uninsured or poor patients, because you want to arbitrage the discount. You want to buy low and sell high to some health plan or to Medicare. And there's a lot of money in this program. One economist studied it in 2019 and found that 340B sales in that year were $67 billion and hospital profits were $40 billion. The program in 2023 had sales of $124 billion. So it's a significant program. Second largest federal drug program. It's bigger than the Medicaid program. And a lot of for-profit PBMs and chain pharmacies have gotten into this program. There's so much money sloshing around in the program that 75% of these pharmacies, contract pharmacies, are now PBM-owned or chain pharmacies. And there's been a massive number of takeovers of, this is another incentive that's misaligned. Hospitals now have an incentive to go into communities that are higher income communities and purchase oncology practices and rheumatology practices. Any practice that's prescribing high-cost drugs, they go in and buy the independent practice. And you're seeing a consolidation in healthcare resources because of 340B, because they can arbitrage more discounts and get more patients. And the program has seen explosive growth, 3,000 hospitals now, and again, a budget of sales of $124 billion in 2023. All that would be unproblematic if the bottom right bullet were not the case, and that is, as this program's revenues have exploded, the amount of charity care being given out by 340B hospitals has been declining. And this is not my data. This is the Journal of the American Medical Association. This is the American Hospital Association. Everybody is admitting that charity care is declining. This is just an This is an advertisement for my think tank. We have a web tool that if anyone's interested in 340B, you can go on and check out. This shows some of the growth in 340B. You know, it had about 280 hospitals when the program started out and clinics, and now it has 14,000. It had 2 contract pharmacies in 1993, and it now has 44,000 pharmacies that are participated in the program. And the green line at the bottom is the number of active contract pharmacies, and that number is 32,000 last year with active contracts. I just want to give some data specifically about Kentucky. There's 63 hospitals participating in the 340B program, and they contract with 469 pharmacies. When you consider contract pharmacies for both hospitals and clinics, the total number of contract pharmacies in Kentucky is 896, with 220 pharmacies located outside of Kentucky. I understand when they're in adjacent states like Tennessee or West Virginia, but I don't understand why 25 are in Texas, 19 are in Florida, and 5 are in California. One large healthcare system has 177 pharmacies, with 74 of those outside of the state of Kentucky, including one in Hawaii. 58% of Kentucky's contract pharmacies are located in affluent areas. And why would that be? Well, because you want to be in an affluent area where people have good insurance, because you want to arbitrage the discounts. And I'm sorry to say this in front of worthy Kentucky legislators, but Kentucky 340B hospitals have some of the lowest charity care provision in the country, 0.68% of operating revenue. The national average is 2.15%. And Kentucky only has one 340B hospital, and I'll call them out for good reason, Deaconess Union, that provided charity care levels above the national average. And here's a look at a list of the major pharmacies that participate nationally in the 340B program. Every one of these pharmacies, including the Cystic Fibrosis Service, is either a PBM for-profit owned pharmacy or a big chain pharmacy. Some of the names don't fit, but ProCare is owned by CVS. Accredo Health is owned by the huge PBM Express Scripts and down the line. And that's what shows up. 84% of non-PBM owned pharmacies are not affiliated with PBMs or chains. 69% of contract pharmacies are. We at Pioneer we took census data of low income versus high income areas, and we overlaid the contract pharmacy map. And what we discovered is that in most states, most of the contract pharmacies are located in wealthier areas. And this is, I'm just repeating what I said before, that this is a program that's now tending to serve wealthier Americans because of the ability to arbitrage the discounts. More and more hospitals want to get insured patients. And let me say for the record, I am very sympathetic to rural hospitals. There are hospitals I know of in Massachusetts that have a high penetration of Medicaid patients. Reimbursements are not even close to being market-based, and they depend on the 340B program. So I don't advocate cutting this program at all, but I think there's some abuses going on, particularly in larger hospitals, and that's why transparency is necessary. Many hospitals, and especially the clinics, work hard to treat underserved populations. However, many more 340B hospitals see the program as simply a profit center. And my recommendation would be, before you engage in some substantial reform, either to increase this program or decrease it, let's find out what's going on in it. Let's find out how much money hospitals are taking in and how much what they're spending it on. And right now, we don't know that. We don't know which hospitals are really kind of doing the right thing under the program and which ones are not. I know there are hospitals doing the right thing. I've studied them in Massachusetts, and I know there are hospitals that depend heavily on this revenue. But I also know that there are hospitals, very, very wealthy hospitals, that have endowments that also give out very little charity care and are not really doing the right thing under the program. Let's find out more data before we start reforming the program. And I'm happy. I'm going to turn it over to Jenny, as what I've been told. And let me end this show. And I'm happy to take questions later.
Okay, thank you. I think you're muted, Jenny. There you go.
This is our world we live in, the unmute, remembering to do that. So I appreciate the opportunity to speak, Chairwoman Moser and esteemed committee members. The National Alliance of Healthcare Purchaser Coalitions is a nonprofit that represents employers across the country. The reason that we are so interested in 340B, and we talk about this at the federal and different state level programs, is because this is a flawed program that raises costs for employers and working families. Dr. Smith just did an excellent job of explaining how 340B works and explaining how it's impacting employers and working families. 340B needs a big dose of transparency. House Bill 685 would do just that by allowing Kentucky to follow the lead of Minnesota and North Carolina, both of which have studied the fiscal consequences of 340B in their states. The Minnesota report revealed the largest hospital systems and not the health centers, clinics, and small rural hospitals were mostly benefiting from 340B. In North Carolina, the state treasurer found that 340B hospitals charge state employees massive markups for oncology medicines. In North Carolina, also the data showed that 340B hospitals reaped an average profit of $13,617 per claim filed for the immunotherapy drug pembrolizumab. I'm not a pharmacist, as you can tell, but one drug per claim. The hospital bought it for about $7,000. Medicare paid them $12,000. Commercial employers paid the state employee health plan, which is like a commercial employer in many respects, paid $21,000 for that drug. And so this is why we need data to help us understand what's actually happening. And a national report recently released further shows that passing pharmacy mandate bills like Kentucky Senate Bill 14 could expand the program and increase costs to state employers by about $99 million in Kentucky and costing taxpayers an additional $16.5 million. So while House Bill 685 is critical measure, it does ensure transparency, and that's what we need. This is a federal program. The more transparency we have at our state level, the better we're able to speak to why the federal government needs to fix this flawed program. And now I'll turn it over to Frank Chemley.
Thank you, Jenny. Thank you, Madam Chairwoman. I just want to make a couple of comments, underscoring what I've heard from my colleagues. Before you as state policymakers consider expanding the 340B program, we as business people believe the better course is to support House Bill 685, which, as my colleagues have said, would provide much needed transparency, much needed data to help you understand whether or not 340B is serving Kentucky well. It clearly is a troubled program. It needs reform. That's up to the Congress. But it is, as Dr. Smith made very clear, a very significant source of revenue for hospitals, contract pharmacies, even consulting firms that are out there helping healthcare systems, quote, optimize, unquote, their 340B programs. It's not free. It is not a free program. It is a revenue source that comes at the expense of payers, of businesses, of employees, of families, and of all of us as taxpayers. 340B is not free. We need you as policymakers, we as employers, as payers, need more data to understand whether or not this program is serving Kentucky sufficiently. So we support very strongly House Bill 685, which would provide that very significant data to help assess how this program is being used. Thank you.
Just to support the comments that have already been made, as an advocacy organization here in the state, we want to make sure that uninsured and low-income individuals get access to these medications. What we don't support is the rapid expansion of a program that has led to its significant misuse. My concern of my constituents, is that the rapid, unchecked growth of this program endangers the program's existence itself. And we want to make sure that through the support of Bill 685, that the transparency comes to the table such that, like my colleagues have said, that we can make informed decisions about what the right course of action is. I've been studying 340B. We've been working on 340B on Capitol Hill since I had hair. And it's not going to get fixed today or tomorrow. But what we have to have is transparency in order to be able to make qualified decisions and pass the legislation that we need in order for this program to survive. Thank you.
Thank you so much for all of your testimony. Obviously, I'm not the expert like you are, and so I don't think I can add anything to your testimony except to say that I think you've made it pretty clear that we just need data. And I keep saying I think this is the session of data. We have Medicaid oversight happening. We are collecting data on healthcare workforce. I think we need to understand the true cost of healthcare and perhaps the gap in reimbursements between the true cost and Medicaid and Medicare. And I don't know how else to help support the federal government as they try to make informed policy decisions without data. And that's all we are trying to do. We want to protect the original intent of this program. I think it probably needs a little more language or some guardrails around how that federal bill was written. It seems a little loose, and just inform our policy decisions on some data. So we do have a couple of questions.
Madam Chair, let me just interrupt,
Yes.
pardon, and say I agreed with many of the things that the senator testified about. One thing I don't agree about is that there is aggressive auditing of this program. The auditing is very cursory by HRSA, and so there are thousands of 340B hospitals. There were 200 audits last year. I think 3 hospitals in Kentucky were audited. And the audits don't look at what you'd want to look at, which is what is in your bill. How much money do they make, and where do they spend it? That's really what an audit should be about. And the HRSA audits don't involve data like that.
So these are spot audits?
Yeah, they randomly pick 200 hospitals a year and they audit them. And they're looking at more things like, are they getting the 340B price? That's the type of thing they look at. They don't look at how efficiently or effectively the program is serving underserved populations.
Okay, thank you. All right, Representative Bray, do you have a question?
Thank you, Madam Chairwoman. I think it's kind of rich that pharma is concerned about somebody's profit margins, particularly in rural Kentucky. But can you explain to me how this is an expansion of the 340B program if we're just saying Kentuckians can't be discriminated against?
I can try to take that question. I don't know. I am definitely not a hospital expert, sir, but from an employer perspective, without the data like in North Carolina to really understand, and in Minnesota, what's happening with the spending and the charges that are happening if a hospital is allowed to buy a drug at a lower rate. And that's partly what Senate Bill 14 is about, this lower rate. The key to the transparency data, the lower rate may be $7,000 that the hospital buys it for. The problem in 340B now, the reason it's a flawed program, is that that dollar amount is then not passed on to Medicare. Excuse me, I'm sorry, Medicaid.
Ma'am, I understand.
Medicaid.
I understand that, but can you tell me how this is an expansion of the 340B program if we say that you can't discriminate against Kentuckians?
Well, what we don't understand is if hospitals or another provider buys that drug at whatever the rate is, it's going to give them an opportunity then to maybe negotiate and get a higher rate. What are they charging the employers? Frank Gemley mentioned the impact to employers. We've done studies at the National Alliance. We understand the impact to employers. All we're saying is before we move forward with Senate Bill 14 in Kentucky or any other state, that we do a better job of understanding the spend of hospitals and what they are charging others. Primarily, the largest plans are employers around the country, and in Kentucky end up covering, many of our populations, and it's coming out of that employer's pocket to run their business. It is a large ticket business item for an employer. Running the Kentucky Employees Health Plan for many years, I understood the fiscal responsibility of a $1.9 billion health plan and doing everything you can to understand every piece of your spend. And so understanding the spend of 340B drugs is really, to me, the first step, and helping the federal government correct the program, because this is a federal program, not a state program.
Okay, we're going to have to keep our answers a little more concise, if you don't mind.
Yes, I'm sorry.
Yeah, I know.
If I may, Madam Chair, answer very quickly. Representative Bray, by codifying in state law a troubled federal program, that strengthens it here in Kentucky, but it's deeply troubled. So that's why it concerns us.
I would argue that we've got a multitude of troubled federal programs codified all throughout state law. But the idea that saying you can't discriminate against Kentuckians is an expansion of a 340B program, I'm not seeing that. When we talk about profit margins, the hospital I was talking about earlier has a 75 to 80% Medicare and Medicaid dependent population. What do you think the profit margin on that is? It ain't good. They're not bringing in millions and millions of dollars and everybody's just flush with cash. They're using this money in rural settings like mine, in places I care about, to provide access to cancer care, which is good for Kentuckians. If we take that away, is that going to be good for Kentuckians, that all of a sudden a little old lady from Livingston's going to have to drive to Lexington? No. None of this makes sense.
Sir, I agree with you on that. There are hospitals in Kentucky who are doing this totally right, and maybe all hospitals are. It's just asking for an opportunity to understand it before we try to codify into law something that is from the federal level. But I do hear you, and I believe your local hospital is using 340B wisely.
Thank you.
And if I may just add one small comment to Representative Bray. Transparency is not discrimination. Those are two different things. What we're looking for here is greater insight into how this program is being used. This isn't pointing fingers at any rural hospital. Mm-hmm. What we're looking at is what unchecked expansion of a program that potentially endangers the entire program because of bad actors that may or may not be involved. But we can't make any of these decisions without increased transparency as to how it's being used. And that's not discriminating against Kentucky. I represent all of these types of researchers, all of these small medical programs. So what we want to see is we want to make sure that these life-saving medications that are being developed here in the state of Kentucky and that we need in the state of Kentucky are getting to those patients. But that's not discrimination. This is increased transparency.
We're all for transparency, but it seems like your all's time would be better spent in Washington, D.C., instead of trying to fix the program that you have issues with, when we're only concerned with making sure that Kentuckians get a fair shake and they're not being discriminated against.
Thank you, Representative Bray. And I think, part of what Senate Bill 14 is, it allows the continued expansion of the contract pharmacies. And so if I could find a way to protect the program and keep it in status quo right now while we collect some data, that is exactly what I would do. So we do have 4 more questions. We're going to have to speed through this because we have to get to the floor. Representative Bratcher.
Thank you, Madam Chair, and thank you for your information. I do have a question for you. You had testified earlier that the charitable or the return rate in Kentucky was the lowest in most states. It's 0.68% compared to an average of a 2 point something. Is that correct?
In fairness, it's fifth lowest of any state.
So is it possible that the reason that it's the lowest is that it even sends another signal how the state's struggling because they're having to use that money for things that you may not consider as charity, such as providing extra salaries for nurses to keep nurses in rural areas, to start new programs in oncology or otherwise, that those really don't count as charity, but they could be count as services and trying to provide for the community. Is that possible?
I think that's a very fair argument, but I know of no hospital in the United States that segregates 340B revenue as it comes in and says, we're spending this money on these 10 things, where you could know precisely exactly what they're spending it on. 340B revenue comes into a hospital and it just goes into the general fund, so hospitals can say that they spend it on anything.
Understand. So just one other question, Madam Chair, if that's okay.
Quickly.
Okay. Have any, just a yes or no question, have any of you four ever been a lobbyist for a pharmaceutical company?
Yes.
No.
Pharmaceutical companies are members of our association.
No.
All right. Representative Dotson?
Dr. Smith, welcome to Kentucky. Did I hear you say you were from Boston, Massachusetts?
I grew up in New York, actually, but I moved to Boston and lived there for a long time.
I hope you enjoy our beautiful state while you're here. But I've never heard of the Pioneer Institute until today, and just wanted to know, what is the background there and who funds that?
Well, I mean, I'll tell you, we do get money from pharmaceutical companies, but we have a broad diversity of funders. We have individuals, we have foundations. We publish data on who funds us on our website. So, and it's not unexpected we would get money from pharmaceutical companies. We study issues that they're very concerned about. So I don't apologize for taking money from pharmaceutical companies, and I talk to them every day because they know what's going on.
Sure. I appreciate the transparency.
Sure.
Representative Fleming.
Thank you, Madam Chair, and I'll try to be as quick as possible. We kept on talking about, and I appreciate Representative Bray where he's coming from, and I'm sympathetic to what he's talking about. You're talking about expanding the program and so forth. There's been an increase, except for last year, of increase of Medicaid clients and patients. So to me, that would say that's going to be a stress and strain for those particular hospitals in order to provide that service, which is going to be more dependent upon what you're doing, where the revenue's coming in. So to me, I understand we want to try to control it and manage that, but then again, don't lose sight of that in terms of we're trying to provide that. So the other thing I want to mention, you talked about buying low and selling high. And I get that. Putting my business hat on, the companies I've owned, I get that. But you all do the same thing. You buy additives, you buy things at a lower price, and you sell at the high. You're not any different than the hospitals in trying to reallocate their assets and their revenues in order to help. What their mission is to help those least among us. So I want to make sure y'all are with that. And I take a little bit note of your affluent, 58% of that. I'm blessed. I come from a very affluent area, but I have quite a few different pockets that are low-income individuals. And so when you see those pharmacies coming, sprouting up, and the Medicaid, they're there. They're still within the affluent. So I take that a little bit to note in terms of be cautious and careful of that. And I also want to point out, in addition to that, these hospitals, they're at 1%. And, you're mentioning that we're low at, 0.68. I get that. But at 1% that they rely upon in terms of trying to reinvest that money, not into stockholders, but into investments like Norton does, $100 million in the west end of Louisville, that's a significant impact. You're going to be really upside down. So, I'm trying to get myself more knowledge about 340B. Like I said before, I don't know much about it. I've only spent about a week and a half on it, and I'm going to continue to look on that. We got serious concerns on Medicaid and how it's going to affect that affect the state. And so during the interim, we might have y'all come back in to talk a little more about how that affects and how that interfaces with Medicaid. Thank you.
Thank you. All right. I think that is it. I really appreciate your, Representative Wilner stepped out. Yes, thank you. I really appreciate your testimony. Thank you for being here with us. I think this was very helpful. I wanted to make sure that both sides had an opportunity to talk about the program and to really try to wrap our heads around what is needed and how we can support the program, but also get some more transparency around it to better inform some policy decisions. So thank you very much for being here.
Thank you, Chairwoman.
Thank you.
Thank you, Member.
Thank you.
All right. The next scheduled meeting of the House Standing Committee on Health Services is Thursday, March 13th. However, it is the last week of session, so that is subject to change. We'll send out notice if that happens, but see no further business to come before us today. We are adjourned. Thank you.